What is up, everyone? Welcome to episode 17. That's a flex, showing you I took 7 years of Spanish.
Whoa.
Yeah, that's
Whoa.
17 for you playing at home. What's up, Adam Green?
I don't think that is 17.
16?
It's close enough, man. It's close enough.
Okay, whatever. I'm trying over it. It's something in the teens. We're definitely episode 17. That much I know.
Yeah, I know that too. Nothing's up, man. Everything is good right now. My wife is out of town, so I'm living the bachelor plus a 6 and 7 year old life, whatever that is. So I go to bed at 9:30 and I wake up at 7, and life's pretty good right now. How are you?
What movies do you watch when your wife is away?
Oh, that's a great question.
It's a family show, by the way.
I don't know. I usually put something crummy on and then fall asleep in it. Yeah, I'm not going through anything good right now. What do you do?
I do action movies.
What's your guilty?
I do like action, like anything Chuck Norris or Arnold Schwarzenegger, just like the most garbage. I don't even necessarily enjoy them, but I enjoy the fact that I'm watching something that my wife would not enjoy, and I'm doing it. And I eat Chinese food, another food that she does not enjoy, and I just do me the whole time. That's what I do. So,
that's nice, man.
So there's that.
Love it. Maybe I'll do that tonight.
Yeah,
it's great advice.
Chuck Norris.
What are we doing tonight? Are we just talking about movies, or?
I'm glad you asked. Tonight, we are going to do something very special. We have two very special guests. We might break the internet. Let's roll the intro, and then we'll talk about it. Tonight, we're talking toxicology. Toxicology? Tox. We're talking tox, and specifically critical care tox. And, when people see pills that kill, that's usually associated with pediatric things. But we're just talking about some deadly things that could show up in the ICU. Emergency medicine is very, very well versed in toxicology. And I think sometimes we get these patients upstairs and we don't exactly know what to do. So we have two very special guests on. And Adam, would you like to introduce
That's my job. So, yeah, we have two guests. So one is Dr. Salzman. He is... I'm looking at Cooper's website. He's got a lot of titles, but he's a director of toxicology and addiction medicine. I think he does mostly ER work, but that's his realm: toxicology, addiction, pain management, ER, etc. And he is you guys will see. He's much
do you know what I do?
Than you and I.
Just so you know what I do with Matt, and we'll bring him on in just 1 second, and he can add more credentials. But every time I work with Matt, every time I see Matt, I'm like, Matt, tell me something new in toxicology, and he does it every single time. So that's Matt.
So either he knows a lot, or you.
It's probably I don't know much. That's probably it. But I know where to get my information. That's for sure.
Google. The second one is my buddy and Firth. I can't do it without him. He's a critical care pharmacist. He runs the ICU out in Inspira, and I'm excited to have him on for you guys to all learn from him. I think the two of them in combination are going to be outstanding.
Let's bring them on. There they are.
There he is.
Good evening, everybody.
And look at this. Look what I got for you guys. Look. Do you guys hear?
Oh,
that was special. That's special. We put a little extra money into that production, but that was just for you guys.
We waited till week 17 just for that. So cool. So what I did, I think, and I'm going to admit up front that probably each of these cases, we have 3 cases, each of these cases could spend an entire hour on. And so we're going to just kind of brush it. And if people are into it, we can come back another episode and dive deeper. And I constructed it by giving a case, and then we'll jump into questions from there. And I should say the goal of these cases when I wrote them is that the answer is obvious. So if the answer is not obvious, then I did something wrong. It's not trying to fool anyone. And I think all 3 of them are cases that I have experienced myself, or at least varieties of it. So the first one's the longest one. So he's a 46-year-old gentleman, obese, chronic peripheral vascular disease, and diabetes, poorly controlled diabetes on metformin. And he comes in because he's confused. And the first thing on physical exam you notice is, first off, his vital signs are stable. Secondly, he's got this right inflamed calf. It's tense. It's angry looking. Not necessarily cellulitic, but definitely painful to touch. And the family says, "Oh yeah, he hit his leg, a week ago or a week prior, and he has, he's been pretty immobile since then." You get some. Let me give you the vital signs. Let's do that. So normotensive, little tachypnic like 28, 30, tachycardic, sinus tach, and satting fine on a couple liters of oxygen. Labs come back. He's got a leukocytosis. He's got a platelets, in 400s, probably some left shift going on, like maybe there's an infection. And then his bicarb jumps back at 8. Creatinine's nearly 5. You look at his UA, and his glucose, we'll say, is 500. I think the first thought is, oh wait, maybe this is DKA, right? He's got hyperglycemia, he's got a anion gap. But then you look at the UA and you notice that there's 4+ blood, no red blood cells, and you get a CK, which is 14,000. That's where we're at. And so what is, like, from a toxicology standpoint, because that's what we're talking about, what are you guys thinking about?
Yes, great question. I mean, we're faced with this anion gap question all the time, and people love, old school mnemonics, mud piles, or, whatever mnemonic that you like. And, in the setting of elevated glucose, low bicarb, acidemia, we have to go through the whole mnemonic, but, a lot of things are going to be unlikely here because it doesn't really, based on the history, it doesn't really seem consistent with a toxic alcohol ingestion. So, kind of brings I don't think we need to go through the whole mnemonic, right? But certainly we have to think about lactic acidosis. And it's great,
Right.
how many times do we see altered patients who aren't able to provide a medication history? But, thinking about elevated lactate and acidemia along with it, um, and then rhabdomyolysis is likely the cause of his acute kidney injury, thinking about metformin-associated lactic acidosis, which
Right.
is not
Perfect.
something that we routinely think about. It's kind of like one of those, I think it's a less common thing, but certainly something that we need to consider for this patient.
Right, and I left that out. His lactate comes back at 16, which I think, from an intensivist standpoint, Haney, you tell me, like, when you see that high of a lactate in a normotensive patient, and a true drop in bicarb that corresponds, like, something's brewing. Something bad is coming. In some ways, it's sometimes even scarier than when they're in refractory shock and you kind of understand it. So yeah, that's what I got. Haney, do you have any questions?
Yeah, I mean, so Matt brought it up, and it's certainly an important point. It doesn't happen often, but then it does happen, and so and then you wonder, how often should we be considering this? How common or just how uncommon is it? Do we have any numbers, or can you just give, in your experience, a global sense of what that number would be, like 10%, 15%, 20% of
Um,
cases?
I don't have a good sense of a number for you, but I think it's uncommon. And I think what it usually comes down to really is a diagnosis of exclusion, right? Like we're going through, again, classic mnemonic, thinking about all the things associated with elevated anion gap, acidosis, and then we go looking for things. And I think one of the things that, at least from an emergency medicine standpoint, that we go looking for is dead gut, right? And now we're looking at the medical pan scan, and is there evidence of gut ischemia that's contributing? But I think, Adam, as you said, like we might expect those patients to be a little more, in shock, hypotensive, tachycardic, really unstable. Although, we had 2 cases at Cooper a few years ago who, physiologically looked the same. And both had metformin-associated lactic acidosis that were really, really sick and in shock, hypotensive, tachycardic, very unstable. And But again, the diagnosis was kind of made after a lot of the other things had really either clinically or radiographically been eliminated.
So that's one of my questions is this a diagnosis that you sort of keep in the background while you're doing all the bigger things that you can actually act on very quickly, and then once you've excluded dead gut, severe sepsis, anything else that be causing this, then you go down that track? Like, at what point do you activate this and say, like, this is something I'm strongly considering it?
Well, I think because the management, at least the initial management, is probably going to be the same. Clinically, I'm going to keep this on the back burner, because if the patient has, if they have sepsis and they have septic shock and I need to get source control, that's a little different than, I need to do that first, right? So I'm going to keep it on the back burner and go looking for other kind of more common causes. Um, and then probably after I've eliminated a lot of those other things, then I'll entertain it. But it's a difficult diagnosis to confirm, right? Because getting a metformin level is possible, but it's not going to come back in a clinically meaningful time frame. It's going to be a confirmatory test that's going to take 3 to 7 days to come back.
Got it. So it's in there. You would treat it as you normally would. Once you rule out the other things, then just by diagnostic criteria, you sort of fall into and say, I guess we're doing this right now.
Yeah.
Okay. First, do you have anything else to add on that?
Yeah. So, I mean, for the most part, we know that our ER colleagues are going to pan scan the patient and make sure that there's no infectious etiology going on that's obvious as we wait for our blood cultures to return. And obviously, broad spectrum antibiotics are going to be started. They're going to come up on vancomycin, flagyl, all the good stuff that obviously isn't going to help in this scenario, but is the right thing to do when we're trying to sort out what's going on. But then here comes, myself, the cop, the pharmacist, is going to look at the med rec and kind of take a look at what the patient's on, and obviously is going to notice that the patient's on metformin at whatever the dose is, and notice the patient has rhabdomyolysis and AKI and going into renal failure, and is going to, bring these questions up to the team that, is it potentially metformin toxicity causing this lactic acidosis, especially when the lactic acid is usually extremely elevated in these patients with lactic acidosis, to where if you've ruled out any type of gut ischemia, most septic shock is not going to produce the lactic acid levels that metformin toxicity does. So, I start kind of going through my algorithm as far as, all right, well, there's 3 different types of lactic acidosis, or 3 different types of metformin-induced lactic acidosis that we kind of go through. So it's either I say metformin is what did it, something's happened to the patient that caused metformin to do it, or the patient has lactic acidosis and they just happen to take metformin and metformin has nothing to do with it at all. So in the case of our patient case here, we're looking at what's considered metformin-associated lactic acidosis, not metformin-induced lactic acidosis, which is metformin's causing it directly. So either the patient intentionally overdosed on grandpop's metformin for their, diabetes, or they have had a worsening in renal function over time that hasn't been caught by the physician that's prescribing the metformin and has led to toxic levels. And then, of course, as I mentioned, the last one is, they take metformin but ended up having dead gut, and that's why the lactic acid was what it was, and metformin really has nothing to do with it. And what we do in the ER and the ICU, as we always do, is we don't use oral anti-hyperglycemics, so they go right on the insulin anyway.
So that's great. Yeah. And correct me if I'm wrong, that metformin-associated lactic acidosis always is accompanied with acute kidney injury, right? It's because the pathophys is that they keep taking their gram twice a day of metformin. They have decreased clearance. It accumulates, and it probably potentiates the lactic acidosis. It's certainly associated with it, right? But it's not the case that, which I think is really rare, where they walk in, normal renal function, take metformin, and have true metformin-induced lactic acidosis. I think that's probably very rare.
I've never seen it.
Yeah, it's this case that I have right here, right? And they look fine. These patients look fine, and then they can't keep up with their acidosis. They become, the tachypnea isn't quite there. They tire out, and then they just, their pH drops, their blood pressure drops, they get intubated, and then it's fast, right? Let me ask, do you mind, Tandy, if I switch gears a little bit? And I mentioned DKA, and I think this is just, we love the diagnosis of DKA because it's usually pretty quick to make. They're hyperglycemic, and they have an anion gap. And so my question is, I think I can see 2 patient populations getting confused. Either those with metformin-associated lactic acidosis that is confused with DKA, so you label them as DKA. And then there's also a group that maybe has euglycemic DKA, but we blame the metformin. And that diagnosis of euglycemic DKA is such a hard one to make. but certainly is out there. And we can talk about that. But I guess my question is the treatment different? Does it matter? Or do we just put all these patients on insulin drip? I mean, Firth, maybe you can help us. Is there a role for insulin drip in these patients with metformin-induced lactic acidosis?
So the way that I would approach it is if you're in doubt and you think that your patient has DKA, whether or not you also might have in the back burner that they might have metformin-induced lactic acidosis, treat them for DKA. Having an insulin infusion running at weight-based dosing, whether they're euglycemic or hyperglycemic, is perfectly safe because we can give them any amount of dextrose that we need in order to keep their glucose levels appropriate, right? So we'll be treating the DKA, but at the same time, if it's on the back burner, the metformin toxicity, there is some literature that has basically shown that using an insulin infusion might actually help in metformin toxicity. So to not go too crazy into biochemistry and the Cori cycle and all that good stuff, but basically what happens is metformin is going to disrupt the Krebs cycle, right? Everything starts backing up, and if we go back into biochem, we know that as the Krebs cycle backs up, lactic acid is going to be produced, all right? The three pathways that lead to the Krebs cycle are glucose, protein, and fat catabolism, right? Breaking it down. So if you can use insulin, which basically will allow for protein catabolism to slow down, which is a direct precursor to lactic acidosis, you might have the potentiation to decrease lactic acidosis just by using an insulin infusion. Now, this is very academic, and has it clinically been proven in studies and trials? No, it's all case reports. So I wouldn't recommend it first line and would say basically, if you think they have DKA, treat them for DKA, keep metformin on the back burner, and go accordingly. But that's the literature that's out there, in accordance with using insulin. And of course, it's something that you're going to have to do in combination with glucose because they're euglycemic or they're hypoglycemic, right? A lot of the times, if it's metformin induced. And you're going to have to watch the potassium as well. So the therapy is called GIK therapy. So it's glucose, insulin, and potassium therapy all at the same time. And you're making sure that you're monitoring those electrolytes and the glucose, and you can use the insulin infusion, appropriately.
I do have to say that we've had a rule on this show that anyone that mentions the Krebs cycle or the Cori cycle, we just immediately kick them off. But the fact that you're so smart and you're drinking bourbon, I think for this show we're going to make an exception. But please,
I appreciate that, guys.
Out there think that we endorse what Firth just said. We hate the Cori
part of my
cycle.
brain.
Like I said, I didn't go into too much detail. I'm sorry.
Hey, I said part of my brain just blew up when I heard that.
Mm-hmm.
Tell Randy Sharp to calm down.
Oh yeah, there you go. All right.
Well, let
Matt,
me ask you a question. Oh, go ahead, Adam.
I was going to say in the because of time, I'm going to throw a whole bunch of stuff at you, Matt. I'm going to list a bunch of different potential treatments, and you can just give me a yay, a nay, or a maybe. How about that? So things I've seen: activated charcoal in metformin induced. When do you use it?
Yeah, really, if it's safe to give within an hour of the ingestion and the patient's not at risk for seizure and charcoal aspiration. Other than that, I don't dwell on charcoal very much. I really rarely recommend it.
Cool. Bicarb.
Can try it maybe to help with pH correction, although I don't think it's going to be particularly effective. And a lot of these patients are often hypovolemic and just need fluid resuscitation with crystalloid.
Cool. How about methylene blue?
I'm not familiar with that for metformin stuff. No.
I'm just throwing it out there. I never let anyone die from shock without methylene blue, right?
And that's super interesting. I think it may have a role in certain other toxicities, but not for metformin.
Adam just thought that you can come on, talk to a toxicologist, and say methylene blue and sound smart. That's exactly what happened.
I can talk about methylene blue if you like with metformin.
Oh man! All right, last one.
I'm open to hearing about it.
No, I just it's sexy, and so I like to say it.
Yeah.
It makes. I was hoping you'd be like, "That's brilliant. How did you know that?" Not the case. How about hemodialysis?
Yeah.
What's the trigger?
That's right. So what's the trigger for hemodialysis? And there's actually a really great collaborative group called the X-Trip group. It's a group of toxicologists, critical care docs, and nephrologists who try to review the evidence for hemodialysis in the setting of poisonings. And they actually have a paper with recommendations for hemodialysis in the setting of metformin-induced, metformin-associated lactic acidosis. And so I think, their recommendations are like a lactate greater than, I think it's 24, or greater than 20 in the setting of liver dysfunction, and also if pH is less than 7.1 to consider hemodialysis. And there are a bunch of other things, and all their information is easily available online. And truthfully, that's what I go to for recommendations for hemodialysis for this and a lot of other poisonings. And so I don't remember it off the top of my head because it's really easily available online. But I think there is a role for pH correction, volume status, and all the other standard kind of things that we use HD for. And if I recall correctly, their recommendations is for HD, not for CVV. But some patients, if they're hypotensive, they're just not going to tolerate standard HD, and so you have to go with what kind of their hemodynamics will really permit.
I like it. So before we move on and change gears, let me just summarize for my small brain what we're talking about here. Patient comes in, they're very sick, they're on metformin, their lactate's elevated. You're going to do the things that you would normally do. Once you've ruled out the things, or if you've ruled out the other things, you start to shift into this, could this be metformin-induced lactic acidosis? And then you're looking for just, again, doing all the supportive care. And then if they meet that criteria, you said a lactate of 20, what was it, 24, 20?
I think
somewhere.
I think it's like greater than 20, pretty profound acidosis, pH less than 7.1, liver dysfunction, and there are a bunch of other things that you can find on their website.
And then go ahead and you can call the nephrologist. But the most important thing that you should take away from this case, and every case we talk about, when in doubt, call the toxicologist.
Give us a call.
There you go. All right, Adam, you got anything else or want to move on?
No, I think we should move on. If we have time, Firth, we will ask you about methylene blue and
I want to hear more about
just a real quick though about the dialysis. So as quick as I can. So the volume of distribution of metformin is extremely large. So it's also important to kind of differentiate acute toxicity versus chronic toxicity. So an acute toxicity, which we rarely see, the volume of distribution, it really doesn't have time to distribute, right? But in a chronic toxicity, these patients that have been on it for years, there's more of the metformin in the plasma. So because of that, dialysis might need to be extended for days. And hemodialysis has been shown to be more effective if it's done over 15 hours, and CRRT is not as effective because of that. So it's important to remember these patients might remain on dialysis for an extended period of time. So the first question I always ask my fellow or attending is the temporary HD cath already in if I'm anticipating doom?
And that's 15 hours duration of the total number of doses or at a time?
No, 15 hours at a time of regular hemodialysis if they can tolerate it, because CRRT, due to its filtration system, does not filter it quite as effectively as hemodialysis does.
That's cool. That's super cool. Awesome. I think we should move on to a second case. So
let's do it.
This one, I give the diagnosis in the case. It says 26-year-old guy, and I had this case. 26-year-old guy comes in after an argument with his girlfriend after an intentional ingestion of 30 tabs of 25 milligram metoprolol. So obviously we're talking about beta blocker overdose. I think we all see this all the time, and they come in such different varieties. So I guess kind of, when are you concerned? When are you not concerned? Are there certain populations that you're like, have a lower threshold to say we really need to monitor them closely? What are your thoughts when you hear this case as a toxicologist, Matt?
Oh, I mean, I take beta blocker ingestions very seriously, and I always worry about metoprolol ingestion. So that patient, goes into, for me, if the resus bay is available, that patient goes into the resus bay, IV access, on the monitor, and as I think was mentioned earlier, just like preparing for impending doom. Yeah, I mean, in terms of like scary beta blockers, I think propranolol is the one that I am most afraid of. And that is what I think Dr. Glaucomflecken refers to as a pants patient, meaning if you call me in the middle of the night with a propranolol overdose, I will put on pants and come into the hospital.
That's
Um,
serious.
yeah, it's real. It's real deal. And truthfully, for a bad metoprolol ingestion, I'm probably going to hightail it in too,
Can I
because
ask you
those patients get sick.
why propranolol? What makes it?
Propranolol, it's not a pure beta blocker. It's got other channel activities. It also crosses the blood-brain barrier the most,
Mm,
causes the most hypoglycemia. It's just really dangerous in overdose, um, and is just not tolerated as well. I think patients clinically do a little bit better, but like some of the really catastrophic outcomes of beta blocker. Granted, it's all dose dependent too, right? So you take enough of anything, it's going to be bad. That's fundamental toxicology. But just like propranolol, it does bad things.
gotcha. And since we're talking about the way things present and whatnot, I've always learned that calcium channel blockers present with hyperglycemia and beta blockers present with hypoglycemia. Is that something
Yep.
you can always hang your hat on if someone says, someone comes in and they're like, I don't know, I just took a bunch of pills. You're like, well, you're normal glycemic, you're fine.
No, I would never make that decision based on their glucose. And especially for our older patients who have co-occurring problems, right? So, like, if they're a poorly controlled diabetic, a lot of diabetics also take beta blockers, right? So, what their glucose is doesn't really help predict how they're going to go. So, you're right, that is the classic teaching, but not something that I rely on really heavily.
Gotcha. And any other specific beta blockers that we should be aware of in terms of unique side? Well, I mean, we'll get into the hemodynamic derangements that occur, but any other beta blockers that have other things that are worrisome to you?
There, so I clinically, I haven't seen too many other of the beta blocker ingestions. Carvedilol, some people argue has a little bit of alpha property as well, so maybe could do some other things, although the real alpha effect with carvedilol and labetalol is somewhat debated. Um, and there's a newer beta blocker that I'm blanking on the name, that I'm actually seeing more and more in clinical practice, but haven't actually seen any overdoses. And then certainly in the Vaughan Williams classifications of antidysrhythmics, there are a bunch of other medications that have beta blockade effect, but really act more as like either sodium channel blockers or other things. So it's hard to say. Um, there's probably, like, again, like you said in the beginning, an hour-long discussion that we could have on you know beta blocker problems, beta blocker toxicity and overdose, um, but probably goes beyond how much time we have today. But I'll stick with my gun saying that propranolol is the one that really terrifies me the most.
Got it. Firth, do you have anything else to add to that?
Yeah, I definitely want to agree that propranolol can be quite nasty, especially if you don't know that that's what they took. But there is one silver bullet that I like to use that we'll talk in a little bit, hopefully, about when we get to treatments for lipophilic beta blockers like propranolol. But yeah, to piggyback on some of the other beta blockers that have other issues, right? So certain ones can block, have sodium channel blockade, whether it's acebutolol, betoxolol, carvedilol. So propranolol as well can do that. So you can see QRS prolongation. Your sotalol is very concerning because that causes QTC prolongation with its potassium blocking properties, where it's used as an antiarrhythmic. And obviously, as he mentioned, your beta blockers that are not cardioselective, that have alpha blocking properties, like your carvedalols, labetalol, nebivolol, obviously they can have vasodilatory effects. So those patients usually present in more of a shocky picture. So those are some things we got to take into consideration, looking at potassium levels and magnesium levels and sodium levels, and attacking those avenues as well as the beta blocker toxicity in and of itself.
Hey, Adam, do you know how I know they're both talking about beta blockers?
Because we asked
They
them
all
to.
they all end in olol. Just so you know,
Olol.
keeping score here.
Thanks, buddy.
Gotcha.
Here's my question. Glucagon. Is it really just an answer for test questions? I don't think I've ever given glucagon. Like, what's
I,
the deal?
yeah, I mean, I've done it a fair amount, and it doesn't really. I don't think it works great, but I've had a couple of patients who've done well with it. But it's the bigger problem that we usually run into with glucagon. One, it causes vomiting. So if your patient's at risk for
Mhm.
cardiovascular collapse, and then they've got vomit, and you're trying to intubate, like we all like a challenge every now and then, right? But I don't want to add mess where I don't have to. And the other problem is hospitals generally don't have enough glucagon to maintain patients on the recommended infusion dose. The recommended starting dose for glucagon is usually 7 to 12 milligrams IV push, followed by that dose per hour, the effective dose per hour. And so we just usually run out of it. And so we can't actually get patients to what is sometimes considered to be like the therapeutic dose to really get what we're looking for. So I try it. I usually don't have enough, and I don't really rely heavily on it anymore.
All right, let's get rid of it then. Let's move on.
Yeah.
Let's
Hey,
talk about
hey.
insulin. Insulin. I think that's what we all do. That's the cool treatment. What I really want to know, sorry I jumped you, Haney, is what I really want to know is what the dosing you start the insulin drip at, what do you maintain it at? Because it is scary high levels of insulin. And I think that most people who do it probably don't give enough. So I'm really not interested in what the textbook says. I'm really interested in, like, Firth,
Yeah.
when you're at the bedside and this happens, what do you actually do?
Well, before you do that,
Well,
can we ask what
Oh,
pulls the trigger for insulin when, I think there's a range of presentations, and I'm curious to know for both of you, when do you say, like, I think this person's going to need um, insulin? And then after that, please talk about the dosing.
so I probably use it sooner rather than later. Going back to glucagon real quick, I like glucagon more as a diagnostic test for beta blocker toxicity. It has a lot of problems. We mentioned the emesis, the aspiration issues. It can cause tachyphylaxis. If you want to give the pharmacy a heart attack, put somebody on a glucagon drip, because you're talking about 1 milligram is $200 to $300. If you're doing 5 milligram pushes and then putting them on 10 milligrams an hour, quite pricey. But it gives me more diagnostic information, which maybe we'll talk about a little later. But as far as the insulin goes, I pull the trigger pretty quickly. Most of my beta blocker toxicities don't present hypoglycemic, because if we think about it, if you're on a non-cardioselective beta blocker, you're inhibiting the beta cells in the pancreas from secreting insulin, so your glucose isn't really getting metabolized. So I will pull it relatively quickly as long as they're euglycemic or hyperglycemic. The first thing you're going to do is give that nurse, and always our overdoses happen in the middle of the night, your overnight pharmacist a heart attack when you put that dosing in, which is, I always start with 1 unit per kilogram as a bolus, and then at least that or 0.5 units per kilogram per hour. So your typical American at 100 kilograms is getting 100 units of insulin, regular insulin, pushed. So we need to make sure that we have some dextrose on board, whether it's D5, 10, 20, 50, whatever I got to make in the pharmacy or have my IV pharmacist make, that's what we'll use. But that's the dosing that needs to be done. And I always like to joke, because people ask me, why use insulin for beta blocker toxicity? And the answer is, well, we really don't honestly know how it works. But the theory is that it kind of shifts from anaerobic to aerobic metabolism, allows calcium to go into the heart, and you get some positive inotropic effect. And that's basically what it does.
All right, great. Let me let Matt back in here. I think he just popped off for 1 second, because I did want to ask Matt. Welcome back. I wanted to ask Matt. You get the phone call,
Yeah.
as the in the talk center. When do you tell them to pull the trigger on insulin? What is it about the presentation? Is it refractory shock? Is it they're talking about putting in a transvenous pacer? Is it anything more subtle than that?
I mean, really, for me, it comes down to kind of the trend. Oops. Can you guys
Yep.
still hear me?
Still got
Oh,
you. Yep.
okay. Cool. Sorry. So it's really about the trend in their blood pressure and heart rate. And if their trend over an hour, let's say, is going down, blood pressure and or heart rate, I'm just going to pull the trigger. And some, studies, or some papers really show that the earlier you start it, the more effective you are, and that the more aggressively you ramp up your insulin dose, the more your map is likely to respond. So yeah, I start early based on the trend in their hemodynamics. And I missed the end of Firth's comments, but we titrate up to 10 units per kilo per hour. And yeah, and we just keep going until we're getting, for me, sometimes it's also just about, are they perfusing their brain? Are they awake and talking? Granted, if they tank their pressure dramatically, they're going to get intubated if they lose their mental status. But my goal is actually to prevent that from happening. And so, maintaining perfusion is really just super important.
Gotcha. And
So
one more question before I let Adam jump in, because I know it's chomping at the bit. In terms of that high dose insulin, realistically, I've heard different things. Some people have said you don't get the hypoglycemia that you think you're going to get with it. I mean, people have good glycogen reserves. I've heard other people who've done much more of this say, "Oh no, you're going to be requiring a lot of D50." So, which is it? Is it really depend on the individual? Is it hard to say until you actually start the insulin and see how they respond?
I think it depends on the individual, because I've seen both clinically. But what I kind of understand is that there are a finite number of insulin receptors in the body. So once you get a patient to your euglycemic state, and we're checking sugars usually like every 5 minutes to and adjusting their dextrose infusion. Once you get them to their kind of maximum insulin infusion, they shouldn't really be at further risk for more hypoglycemia. Achieving euglycemia is a real thing, and you should be able to continue to titrate up your insulin dose without further risk of hypoglycemia, theoretically.
I love it. Thank you.
That's great. So here,
And those patients should also get, I want to say also, just as because we never really know what a patient's given nutritional status is. And so if we're maintaining patients on prolonged dextrose infusions, they should probably get some thiamine too, just as a little aside.
Great. Yeah. So I want to make it a little bit more practical. So you're titrating the drip up. What are we targeting? If they're hypotensive, you're going to continue to titrate up as long as they're hypotensive? Or is there a heart rate that you're targeting to? Like, what are we targeting? That's the first question. The second question is, are you checking glucose every 15 minutes, or what are you telling the nurse? And then the third question is, how about things like electrolytes? I'm assuming the last thing I want to do is take a patient who's got an arrhythmogenic overdose and then make their potassium 2 because I'm giving them 100 units of insulin. And so
Sure.
Are you checking every 4 hours? Like, what are the audience, let's say tonight they have one come in, what are the orders they're putting in?
Yeah. Well, and I feel like I need to say one other thing. So I think things are very different when I'm on the phone and when I'm actually at the bedside. And at my previous job, we had, I used to work up in North Philly. We have toxicology fellows up there, and I used to tell the fellows all the time that there's probably no consultant that's more ignored than a medical toxicologist, right? Because I walk into the room and I say, give this patient 10 units per kilo per hour of insulin and a dextrose infusion, and people look at me like I'm crazy. And certainly when I'm on the phone and I make that recommendation, and I don't know the person on the other end, because when I take call for the poison center, I'm getting calls from all over the place. They're like, who is this guy? Right. So I really just try to be very algorithmic about it. Right. And so for me, make sure the pump is full, make sure the tank is full, crystalloid resuscitation. If they're not responding to that, the truth is some people say that norepi is perfectly fine. And this is debated in the world of toxicologists too, that maybe we don't need the hyperinsulinemia euglycemia therapy, and most patients are actually going to respond to standard vasopressors. So Adam, I respect your question, but I think it gets just a little bit more complicated than that in terms of like, where is the patient? What is the provider comfortable with? What's the clinical setting that they're in? And, so anyway, but if you're calling me and you're on the phone with me and they've got a concerning trend with their heart rate and blood pressure, and we're okay with starting hyperinsulinemic euglycemic therapy, I'm along with Firth, 1 unit per kilo of regular insulin, IV push, start them at 1 unit per kilo per hour and titrate up to 10 units per kilo. And maintain.
And here's a secret. Here's a secret that you can tell all your pharmacy buddies, right? Because we're not using this for patients that are hyperglycemic. You can actually mix your insulin infusion in D5, D10, D20, so that you're infusing it not in saline, but in actual dextrose, which might also help with your hypoglycemia.
Yeah, I like that.
That's really cool.
Matt,
I like that.
Matt, that was the nicest way of saying thank you, but no thank you. I asked a question and you just shot me down. I love it. And by the way, I definitely ignore Firth more than I ignore you. So if that means anything,
I'm used to it. I'm so used to it.
Thanks.
And I don't want to correct any of you guys because you all are very smart, but don't forget about the Krebs cycle when we're talking about all this. Anyway, next question.
So let's. I really want to get to the third case, and we're kind of running out of time. So I think we have a decision to make. Do we save the third case and just keep moving, or do we? What do you think?
I don't know. Let's ask the audience. Why don't you drop in the comment if you want us to keep going with the third case? Otherwise, we could do Q&A while we're hearing back from the audience. And by the way, don't forget to like and subscribe to the channel. That's the way we get more of this content to you. Matt, is this the beta blocker you were thinking about?
Yeah, I think so.
Yeah. All right.
I think so.
So
Randy,
you haven't seen the overdoses
so
of this yet, but I'm sure people will find a way.
In the meantime, let me ask, I want to hear about two other treatments, and that's the use of inotropes and beta blocker overdose. And then Firth alluded to it, but I do want to hear his take on lipids.
So, I personally like using milrinone, right? So if I'm dealing with someone with a beta blocker toxicity, the last thing I want to do if I'm dealing with a scenario where they're in cardiogenic shock, we're not dealing with just a chronotropic problem, we're dealing with an ionotropic problem, is use something that works on the beta cells because they're already saturated with a blocker. So dobutamine is not going to work for me. That's why we don't really get much response out of epinephrine. Norepinephrine probably works a little bit because we're getting that alpha block or that alpha agonism, right? So we're getting more of that MAP elevation from, vasoconstriction. But I like to use the glucagon, as I mentioned earlier, as a diagnostic test because it works by increasing cyclic AMP, which causes positive ionotropy. Well, milrinone works similarly with phosphodiesterase in increasing cyclic AMP. So it has the same pathway. So if I get a response to someone on glucagon, I like to use milrinone in that cardiogenic shock picture. Now, caveats is milrinone is going to cause vasodilation, and if they're already hypotensive, you need to be careful with the hypotension. So that patient I'm probably also going to have on Levophed in order to maintain a good afterload, stimulation. But I like to use milrinone in that setting because it really does get around that beta receptor and allows me to get some, cardiac contractility. As far as did we want to talk about TVPs, or do you want to leave that for another conversation?
No, I think the answer for TVP is easy. If there's an indication, you put it in, right?
Gotcha.
Like an indication is the same, whether it's beta blocker or it's not beta blocker, right?
Yeah, that's fine. So I was going to go, that's fine. But yeah, and then obviously if the patient has renal dysfunction with a milrinone, we got to be cautious and obviously renally adjust it there. But I like to use milrinone in those scenarios. And then as far as the lipids, I'm a huge lipid guy. I know, the infamous Randy Sharp is on here. So him and I have used lipids in the past when he was a fellow in different overdoses. But if we're dealing with drugs like propranolol that are highly lipophilic, using, lipid emulsion, 20% lipid emulsion has the ability to encapsulate that lipophilic medication and kind of pull it out of the patient's system while simultaneously providing some calcium influx into the heart, which allows some ionotropic property as well. So I'm a big lipid guy, and I don't really see much downside to it. Most of its side effects are associated with long-term use, TPNs, things like that. But I like to go to lipids relatively early in patients that have taken a lipophilic beta blocker.
There it is.
Yeah.
There it is.
But I would not expect metoprolol. I wouldn't expect metoprolol to respond to lipids. It is not
at all.
If I recall correctly, not one of the lipophilic beta blockers.
Correct.
I guess that's
Beautiful.
a quick question, and I want to get everyone's shouting for the third case. So like I hope
All
you
right,
guys, if
we'll
you had
move
something
on.
important like a kid's graduation or something, cancel it because you're going to do the third case. But what I will say is that for a while, intralipids was one of those things where people said, well, if you have any tox, just throw it at it. It can't really hurt the patient. Is that true? Or are you worried about the potential side effects from it? Should we be tossing it at anybody who's really sick and dying? What are your thoughts on that? Should you just give it willy-nilly, or should you really be selective? Like if the person you know comes in with a metoprolol overdose, I'll be deliberate here. They're not doing poorly. Would you throw intralipid at them because they're circulating drain, or say it's not going to do anything and there's lots of potential harm?
I don't think there's a lot of room for harm, but I really wonder about the upside in a lot if just using it willy-nilly. Like in an undifferentiated, poison patient, um, right. I don't think you're going to do a lot of harm. It does screw up your laboratory testing going forward after lipid infusion. And so may cloud some, may make some of your clinical decisions a little more challenging. And then, we didn't even, broach the whole ECMO question, but like we've seen patients who've gotten lipids and get onto ECMO, and how does that complicate things? Um, but I think early on, you're right, Haney. There was like, I think a lot of I think what it came down to was a lot of publication bias where people were like, look, this is like the greatest thing. This is going to fix everyone. And, to give credit, the first study that actually showed harm with lipid emulsion therapy was done by a toxicologist named Anjanette Guide, who's, a really smart woman, and found that, it actually didn't prevent mortality, and a lot of patients who got it died. Now, it begs the question of, were they going to die anyway because they were just so sick? What else was going on? There are a lot of still think there are a lot of unanswered questions about it, but again, as a Hail Mary, so to speak, I think it's probably worth a shot at the end, but I would
Yeah.
not just give it routinely.
I have to piggyback on that real quick. So I'm actually published in Chest for using lipids in a patient that came in and took, who the heck knows? They just said they took a party box, and it was, as you mentioned, the Hail Mary, and the patients, you go through all the toxidromes. It's like, all right, well, they're breathing on their own, and I'm not worried about this. And, they only have the bradycardia, but they don't have this, and kind of just going through the systems is like, well, maybe they took something that's lipophilic. Here we go. And it reversed everything, and the patient went home the next day. So I agree. It's that Hail Mary, and the incidence of side effects are so low that why not?
Did you say published in Chest?
Yes. Randy Sharp was the fellow on that case.
All right. All right. So what do you say? We got a decision to make here. Do we blast through the last case, or do we just bring these guys back because we're having such a good time?
I honestly think the answer is bring them back.
Bring them back.
I just so everyone knows, it's Tylenol, and I think we could easily do Tylenol for a whole hour.
Maybe what we should do, and we should ask them, is let's do an episode on Tylenol as well as general liver failure and the use of N-acetylcysteine. I think that could be easily a show. What do you think? Oh, Matt's rolling up his sleeves.
Knack for all. Knack
like
for
any
all.
toxicologist's
Knack for all.
favorite antidote, right?
Yeah,
I think.
right?
Yep.
It's mine.
All right, so let's do that. Let's bring you guys back on at your convenience. This is one of the biggest shows that we've had. We have a ton of viewers. We have a lot of interaction happening in the chat. Let me turn over, and everyone's saying bring them back. You guys are famous, and let me ask now in the comments. Does anyone have any questions that they want to ask these group of gentlemen before we let them go? Here we go. I got one from Michael Bonk.
Hold on.
Oh, go ahead.
Let me just say one thing. The question cannot be, can you please do a third case? You're not allowed to ask that question.
And it cannot be talk about the Krebs cycle. I will ban you from the chat. How about this?
I'm done with the Krebs cycle. All
right. I forgave you, but let's just take it easy on the biochem. All right. Any thoughts on lipid emulsion and cholesterol emboli?
There is some literature that shows that you can, get fat emboli from lipid emulsion, but I believe most of the literature is with the use of lipid emulsion in TPN, not with drug overdose. So as far as I'm concerned, I'm not aware of any literature associating it with using it in an overdose situation.
Yeah. I think a theoretical risk, but low.
Okay. Next question. Who wants to be a billionaire right now? Because looks like if you guys can come up with this formulation, we might be onto something here.
Well, it's all about the acronym, right? You just have to find something that makes it sound sexy, right?
Yeah.
I'm not good at that.
All right.
We'll leave that up to Adam. Adam loves the sexy disease states.
Yeah, that's right. Yep.
Adam's a brand guy.
Yeah, that's my thing. There's two types of people in the world: generic and brand.
This is a good comment that I wanted to put up from. I think this is. Well, I don't want to shout this person out, but I believe they're a pharmacist from an institution that I work at, and this is going back to the comment about high dose insulin. Any thoughts on this?
I can't actually read the whole question.
Oh, is it cut off?
I can actually. So this is actually published in a case report that I wrote with this pharmacist. So and props to the pharmacist who really did most of the writing. But yeah, the way the insulin infusion is often mixed, and hung, it can lead to a lot of volume going into the patient. So you can actually do a concentrated insulin infusion. And so certainly, patients who have beta blocker ingestions are at risk for decreased cardiac output, pulmonary edema if they get hypervolemic, and if they're older and at risk and they have a history of heart failure and they're prescribed a beta blocker, certainly at more risk. So there is an opportunity to create a concentrated insulin infusion that will result in less volume to the patient, and that can be helpful.
Yeah, call the pharmacy. We can do all kinds of tricks and things, but at the end of the day, the question becomes, does the pump that's in the patient's room have that concentration programmed? And if it doesn't, the next question is, how quickly can biomed get that concentration programmed into the pump? Because if they can't, it's going to be very difficult to get a nurse to run an infusion that is basically freehand.
So the pharmacists don't have like a cheat code, like up, down, down, left, right, A, B, A.
Block, like BB. Yeah, no. No Mortal Kombat cheat codes.
That's a good reference. All right. Any other comments? I'm going to hit you guys with some rapid fire questions while we end out this show. Best cheesesteak in the Philadelphia area?
Tony Luke's.
That's a good one.
I'm probably a Pat's guy. I think that's where I went the most during college in Philly.
Okay. Adam, what about you?
I'm not going to answer, and I have strong opinions about this, and I don't know if this is the appropriate venue. Everyone loves to talk about cheesesteaks. There's like 45 better lunch things that Philly does that I just can't even. They're all crap.
What are you, anti-meat now? What are you, turn vegan on us?
I mean, that's a fair question. I'm allowed to ask it. We're in the Philadelphia area. What?
Yeah.
Okay, Adam. So what's a better food than a Philly cheesesteak?
In the reality, I just didn't have an answer, so I was just trying.
Okay, fair.
In Spirit Cafeteria.
I love John's roast pork. I think there's. I'm a fan of roast pork, not provolone, some broccoli rabe on there. I'll take that any day over a cheesesteak.
And listen, for the vegetarian option, you can't go wrong with Dizengoff hummus. It's really good.
There you go.
Matt with the shout out. Matt, you are, I'm going to say it, and I don't know if you're officially a foodie, but I feel like you are a foodie. Would you call yourself a foodie?
I would call myself a foodie, yeah.
Yeah, because I mean, when I talk to you, you know what you're talking about. I ask you like, hey, what's the best? And you always have an answer for it. So I do consider my local foodie. What would you, accept it, just accept it. What would you say is the best Mexican cuisine that you know of in Philadelphia? And it doesn't have to be sit down, nice tablecloth. In fact, the opposite
No.
would be just fine.
I mean, I think there's such a spectrum of Mexican food that you can get in Philly, and it's a lot of it is just so good.
Hmm.
But the chef owner of South Philly Barbacoa, recently opened up a place. I believe it's called Casa Mexico, if I'm not mistaken. But I could, yeah, is that right, Adam?
I
Which
think
is
that's
right
right. Yeah.
down on South 9th Street, where it used to be a concert venue, and she took over that space. And not only is her food amazing, but the community work that she does is
Mhm.
also phenomenal. So I will give that just highest recommendation.
All
Yeah,
right.
that the episode of what is it, Chef's Table on her and her husband is just phenomenal. So for people who like that type of stuff, I definitely recommend checking it out.
Yeah.
All right, my last question, and then if Adam has any questions, he can ask, and he can tell us what his favorite food is. All right, last question. Best pizza. This is near and dear to my heart. Matt knows this. I've brought it up a couple times.
I'm
on the
pretty
show.
generic. I'm good with a nice pepperoni pizza.
No. I mean, what place? What spot?
Oh. Well, I'm down here in good old Cumberland County. So for us, I got a place called Deli Plus that's around the corner from my house that is phenomenal. Can't beat it. They don't deliver, of course. So I've been drinking. I can't go get one after this event here. But great pizza there at Deli Plus.
Deli Plus and pizza. Those words have never been in a sentence together ever. But I'll take your word for it. I'll take your.
And
Hey, close on Sunday. Close on Sunday.
That's fair. That's a mark of a good pizzeria.
And look, pizza's come a long way over the last years, and actually sometimes it just gets really snotty in Philadelphia too. I mean, there are
Mhm.
places where you have to go online, order it in advance, then you go pick it up on the day that you actually reserved your pizza, and it gets to be a little bit much. And then it's do you like, really like Neapolitan thin crust style? Do you like the thick crust, double rise, sourdough? There's just so many different things that you can get right now. There's a lot of good pizza in Philadelphia.
All right. I can't get it. Can't get it. Deli Plus is the only answer I got so far. Well, thanks. I'm going to go out on a limb, and I'm going to say that the best pizza that I've had, and someone actually already commented, so I know this is up, is Angelo's, which used to be right down the street from me in this neighborhood that I'm living in now. And they moved to Philly, and they are legit. And apparently they make a good cheesesteak too. But that's, in my opinion, the best pizza I had in Philly. I will tell you that this weekend I went to New York City to Brooklyn, and I had DeFara's Pizza for the first time, which is supposedly on the One Bite app, the top pizza reviewed. And each slice was $5, so I was having high expectations of it. And I have to say, it was very mediocre. Very mediocre. So it just goes to show you can't trust everything on the internet.
All right.
All right. Well, that's what I got.
You mean like this? You mean like this show? You shouldn't trust us, right?
just like the show.
Very nice. Very nice. Adam, anything else to close the show before I let these gentlemen go?
No, I really enjoyed the show. I thought there's so much knowledge dropped, and I love the comments. I think it's probably my favorite show that we've done so far.
This show was awesome. This show was incredible. Thank you so much for being here, gentlemen, and sharing your knowledge with us, and not getting crazy into the physiology, which I always appreciate, but very clinical. And so will you come back and talk to us next time about some?
Absolutely.
Awesome.
Anytime. Thanks for having me.
Awesome.
Perfect.
Had a great time.
Thanks,
gentlemen. Thanks for being here, and we'll see you soon.
Thanks again.
Adam, that was on the Mount Rushmore of Critical Care Lounge episodes. I'm putting it right up there. I don't know if it's George Washington or Lincoln on there, but it's up there on the mountain.
It was great. I loved it.
It was
I feel compelled to teach one more thing. And Matt mentioned the lipids and ECMO and how that would be a contraindication. And I felt like we should have like expanded because that's so interesting. And that the thought being essentially that it would clog the oxygenator. So patients who are to the point where they require lipids and then they continue to go into refractory cardiogenic shock, potentially a reversible scenario, then you would put them on VA ECMO. Similar thought why a lot of people will say you shouldn't use propofol in ECMO is that it will clog the oxygenator. And I just thought it was we breezed over it, and I felt like we should go back a little bit and talk about it.
I know you love ECMO, so
I do love ECMO.
That's a good point. Listen, couple housekeeping tips or things. I do want to tell everyone, thank you for watching. We really appreciate the support. The channel has been really growing over the past few weeks, and it's all because of you. So please like and subscribe. It gets the word out to more people. Whenever you see the contents coming on, please share it with your friends and encourage them to come. We like to be interactive. We like to be engaging. And we're planning a show for the future where we'll even get some of you up on the screen to say hello to you, and so you can ask questions live. That's something that's in the works. The second thing, ResusX is a conference for resuscitation that we do every year in November. Adam is actually giving a talk on proning patients with ARDS. And so that's coming up November 1st through 3rd. If you want to watch a virtual conference with some of the best speakers there are in resuscitation and critical care, go to resusx.com, RESUSX.com, and sign up. Right now it's early bird pricing, and we'd love to have you come to the conference. And what else do we have? Adam, what's our next episode?
I was going to say, and we haven't figured out the logistics, but we're going to do some sort of like ResusX plus critical care lounge mixture, right? We're going to try to have a lounge at the conference. So we haven't figured it out, but that'd be great.
Yeah, good. Thanks for reminding me. We are going to be doing I think it's our second night. We're going to be doing, is it the first or the second? We'll get you the details.
I think the first. Because
the conference is going to be the first, and then right after the conference ends, we're going to go right into the lounge. So it's going to be highlighting some of our speakers. It's going to be a really big show, so definitely want to stay tuned for that. But if you want to see the whole ResusX conference, definitely go and sign up now. Tickets are limited because it's an engaging experience where you are part of the show. And what else? What's our next show, Adam?
Next episode. So I don't think we have our speaker. I haven't fully decided on what the topic is, but it's going to be a trauma topic. I think either maybe massive hemorrhage or approach to massive transfusion, or I kind of like all hemorrhage. I think, probably just the traumatic hemorrhage and what do we do? And when do you surgerize? When do you flex your medical muscles? What do you do?
I love it. You know what I think we should call it? There Will Be Blood.
Gosh.
Because I'm a huge Daniel Day-Lewis fan. And
that's why you're the boss man.
Huh? What?
That's why you're the boss man. That was so good.
If you have a milkshake and I have a milkshake and I have a very long straw. You got to watch the movie. Anyway, so that's coming up soon. Stay tuned. Thank you all for being here. Adam, thank you for being as handsome and charming and smart as ever. I always appreciate doing these shows with you. And I think this was a huge success today.
Yep. And thanks to our audience. Wonderful, guys.
That's right. Adam always showing how selfish I am. Thank you, everybody. We appreciate you, your support. And again, like and subscribe to the channel so more people lay eyeballs on Adam's handsome face. All right. With that, we will see you soon. Bye, everyone.
Good night.